Welcome, everybody, to the Blueberry Pediatrics podcast. Today, we are thrilled to have Dr. Kay Judge, a leading voice in healthcare management and health equity. Dr. Judge serves as a chief medical officer at Meridian, Michigan, a Centene Corporation, where she drives impactful changes in healthcare delivery. With expertise in Medicaid and Medicare, disruptive technologies, and value-based care, Dr. Judge is at the forefront of healthcare reimagination. In today's episode, we'll dive into her approach to leadership, the future of healthcare, and the importance of health equity in driving business success. Thank you so much, Dr. Judge, for joining us. I'm so excited to have this conversation.
Well, thank you, Dr. Garbi, to you and your audience for having me. This is exciting, an opportunity to talk about a field that I think most clinicians innately know, but is becoming more and more called out and more prominent. And I think hopefully through the end of this discussion, what we'll find is, especially with pediatricians, this is something that any one of our pediatricians could have spoken, or any one of our internists, family practitioners could have given this talk. And I think what's reassuring is that this visibility at a level of structural change is actually happening. So I hope this is a positive conversation. I hope people walk out of here inspired and also gratified and feeling a sense of acknowledgement for the work that's already being done in health equity among all of our practitioners.
Yeah, absolutely. As a clinician on the clinician side, which I am as well, I feel like we don't in the health space know all the things that go on your end of things. So I think it'd be so interesting to learn about all the things that you are doing and that people in your space and your position are able to, the impact and change that you're able to have.
Absolutely. Absolutely.
So before we dive in, I'd just love to know more about you and what drove you to this space, and especially for those who are MDs, it's a different kind of pathway. So I'd love to hear a little background on that first.
Yeah, it's a great question, and it answers a question that you said before. How does it factor in? So I'm an internist by profession, practiced medicine, carried a full panel for over 25 years. And when I talk health equity, about 10, 15 years ago, I think there was this national conversation on health equity that started coming up. Of course, it had been happening before that, but then we started seeing, like, HHS came up with its 2000 strategy for health equity, and that cascaded down from the federal government. Different state governments had different interpretations and different 5-year, 10-year strategic plans. Yes, the CMS is incorporating more visibility into health equity. So I think there's an evolution. For me personally, it was about 10 years into my leadership. I think there's a space of working as a doctor where you're either burnt out or you try to be part of the change. And for me, it was more, if there's an issue, then I need to figure out how I can solve it, not just for my patient, but from the perspective of structural change, and population health. And in that, I think that those are the places where I just had a segue of my career into more and more population health. How do I take focused populations and how do I drive quality? And that's how mine started. How do I drive Medicare quality? How do I get to that 4.5 and 5 stars? And as I started going there, I noticed we can hit quality, and there's ways to do it, but the barriers are not clinical. 80% of the times, data has shown that our barriers to achieving health are socioeconomic. And so when we're looking at quality, and if my discussion is get a colonoscopy, then that discussion isn't not only do I have a gastroenterologist and do I have access to a colonoscopy center, Cologuard, or whatever is, but the answer is, where are the other barriers? I think the other turning point for me, my goosebump moment and aha moment and utter humility moment was when I used the term with a mentor, non-compliant patients. I have patients who are non-compliant, right? Not pediatrics, because all peds are. But as an internist, and my mentor stopped me and said, "Stop right there, Kay." He said, "We don't have non-compliant patients. We have patients we have not yet earned the trust of."
Right.
When we speak of health equity, right? So for me, the turning point of, well, where there's this element of which I think we intuitively are as primary care practitioners, of cultural literacy, of awareness of socioeconomics and how that might be impacting our patient care. But, taking a step back of what if I can also help with the organization to say, this is my cohort population when I'm planning for Southeastern Michigan. Well, then I already know that food insecurity and housing insecurity is a key. I already know that these are the disparate measures and these are the cultural nuances that I'm going to have to surpass or speak to cure this, not just get a colonoscopy out there, right? So I think that it's, for me, my evolution into health equity was a desire to bring quality into our population space, but also recognize our barriers to quality are not just clinical; those are socioeconomic. And when we address both of those, then we equilibrate that playing field to achieving quality care for all of our members.
Gotcha. Yes, it's definitely hard to see all this though from like an in-office perspective when you're grinding and burning and trying to get through all your patients and have them like fall in line with what you need to take care of in a day. So the broader perspective is just so important to hold on to. And it's so interesting to see how you can impact that. So now your title is Chief Medical Officer.
Mhm.
What does that mean within the corporation that you're in, and how are you able to bring health equity to the forefront? And I'm sure I have so many follow-up questions because that's a big one.
No, I like that question because it's when I first went into managed care, and interestingly enough, from Medicare, there wasn't much of a difference for me when I did Medicare from the perspective of a healthcare organization to managed care side, right? The delivery of care, patient centric, making sure your care gets delivered. I think that there is a alignment there, and I think like a lot
Mhm.
of physicians, we're often looking at the areas of abrasion, and there's this bucket of work that needs to be done by a health plan that we are held accountable to as a health plan by the state and federal bodies, that quality measures, that if you don't hit these quality measures, you may not get a contract in our state. You have to rebid in our state, but you have to show how did you deliver quality. And then you say, how does managed care actually impact that? Right? It is, if, let's just say Southeast Michigan, who's my network of providers? What are their quality measures? What support do they need? Where, how much access do they have to data? Real-time access, how can
Mhm.
they, what gaps do they have to close? What help do they need closing the gaps? Is it pharmacy help? Is it quality outreach? Is it member connections? Is it community health workers? We have a cohort of, we have 50 community health or workers in our organization. Is it sending someone to their house? So there is literally an army of outreach that happens to the patient that is out in addition and in collaboration with our primary care providers. And I think that that's how health plans can come into play. And when we talk about health outreach, then I think that stepping back is that collaboration, those areas of collaboration are done through the filter of data, right? We, with health equity, it's SDOH data mining. Where's our population density? Where are our gaps in clinical care? And where's our SDOH gaps? That we need to fill, and then those solutions then can be tailored for them. Then this is the outreach that this member has. Um,
So interesting. So when we're talking about healthcare delivery, in terms of what you're responsible for is what all these social determinants of health, which are the basis, from what I'm hearing, I think, to make sure that the other in-office things for doctors can actually happen as effectively as you want them to, and that becomes your responsibility, which seems like outside of what you'd think the scope would be almost.
right, and it isn't right, and I think that we don't. It's a part that if it happens right, it's seamless and no one sees it.
Right. So
Right.
I think that's so interesting. Seamless and no one sees it, but you're doing so much work in figuring out what's needed, data mining, and then putting in these innovative programs, especially now with all that, technology is capable
Mhm.
of, to get to achieve those goals. So I'd love to hone in on some of these goals and how you've been able to achieve that.
Absolutely. So for, just bringing in, oh gosh, there were so many beautiful points that you mentioned, and I want to talk about each of them. But let me get, and we can pause here and go forward. The goals that for our organization that we want to achieve for Michigan are very much aligned with the federal goals. We know that health inequity, it impacts us nationally to the tune of about $90 billion a year. Just the disparities in healthcare. And that's just the disparities. Then there's the loss of productivity that's aligned with the disparities. That's
Right.
almost an equivalent amount. And
Can
what
I
we're,
ask you to
yeah,
double click
yeah,
into that? Like the disparities that are causing that huge loss. Can you give me like a little insight into what those are?
absolutely. So the estimated cost nationally of racial and ethnic health disparities, and I think this was about 2 years ago, is $93 billion. Just the
Wow.
disparities, right? Like we have our Black American population, our Native American population. If there's a 10% discrepancy, in cardiovascular disease screening or just
So
cardiovascular
that number would be like how much more we're spending on a different population.
how much more we're spending, because if everybody was as healthy as the healthiest population,
Hmm.
right? And the healthiest population, think of someone with all the socioeconomics, middle class
And access.
income, it's access to healthcare,
Hmm.
right? No ACEs, no, right? No, right? So all of those issues then lead to, let's say if that's a threshold, and over and above that, because of all of these socioeconomic issues, racial disparities, structural issues, that we're spending $93 billion. We're also spending an aligned $42 billion in untapped productivity. When people get sick, they can't take care of their family members. They can't take care of their children. They can't go to
Right.
work. And so we have a national cost of healthcare disparities. And I think it's really important to quantify, because this is not just a nice to have. This is something that if we resolve, we know that we are in a healthcare funding crisis nationally, where the cost of healthcare is escalating. We're looking for solutions. Is it Medicare for all? Is it just honing in on what we do? But another way to approach is what if we had equitable healthcare for everybody? We would not be spending as much on the healthcare delivery, right? So I think that
Absolutely.
that's a point where, and I always like to bring as physicians, I don't think we normally think of finances, but if we really want to align resources to things we need done, then we need to show where the ROI is. Where's that return on our investment, right? And it is a business proposition. For me, it's a compelling moral imperative, right? Like
Yeah.
all my patients they all need their vaccinations, right? Like
Right.
no child should have polio, right? No child
Absolutely.
should have measles.
Right.
And every mother needs prepartum and postpartum care. Um, and I think, and however, in the state of Michigan, 12.7% of our mothers who are Black, there's 12.7% more who don't have prenatal care, right? So and we know that impact then on everything, right? Just overall health of the mother, health of the child, prenatal delivery, or low birth weight and or complications in the infant,
Right.
right? And then postnatal, we have another gap, as well as all the cancer screenings, immunization, same story. So there's a
Hmm.
gap in healthcare delivery for various racial and ethnic groups and various socioeconomic groups. And I think when we talk about health equity, a lot of us intuitively know race, but we don't think of the rural health disparity as much, where those of our members who are living in these rural areas are in healthcare deserts.
Yeah.
And you say go see your OB and it's going to be 60 minutes to do it, you're going to miss your prenatal appointment,
Right.
right?
Or not go or
Or
skip
not go,
it.
right?
I know there are people traveling 3 hours to reach a pediatrician in parts of the country.
Yeah.
Yeah, it's
Right.
rough.
So for that, I think that healthcare delivery, those are the areas that those are the disparities we see. Those are imperatives. And then I think like the next question is then what is the solution?
Right. So I was
Right.
going to ask you that, but I don't, I don't know if that's fair, but I would love to hear in your role, like what impact you can have and what you've been working on to try and fix these things.
Absolutely. And I think that this is where where I love to see more physician leadership, right? Because I think
Yeah.
that when we have, I think there's a clarity about being a physician. Your patient either got their immunization or they didn't. They got their colonoscopy or they didn't. There's a clarity about evidence-based medicine, healthcare delivery, and that need, of what we need to do. And I think that when then physicians are at the helm of health equity also, then there's an academic health equity. And in that, there's a lot of barriers. And I think that clinicians can go past those quickly to say, okay, I know that it'll take 20 years to decrease these structural barriers to my patient's access to care. But there's a solution today that I'm going to incorporate to get Jimmy to his immunization. And I think that that's part of what we do as a health plan, where we start looking at we're contracted with a vendor for transport. What do we cover? What's the range we cover? Where do we cover? How do we call them up and say, hey, you got an appointment, get there, right? Because we may not solve the fact that there's not doctors everywhere, but we can get the patient to the doctor, right? So where are the quick and easy solutions to kind of closing that gap in healthcare, and and then let's look at the long-term solutions, which is racism and bias, which is structural inequity, which is, the other issues that cause, this disparate healthcare system in different areas. Rural health disparities, rural hospitals do poorly in quality. Are they poor quality organizations, or are they taking care of the sickest of our sick? And do they need extra money? Knowing that we do that, and that's where SDOH can also come in. I'd also say I'll throw in, just so we can talk about solutions so physicians can get an idea, because I want us to be inspired and not overwhelmed by health equity. And it can be very overwhelming in a room sitting with a patient who get this, and they may not have running water. They may not have electricity. They may not have a house. Mom may be close to being homeless, right? They may not have cultural literacy. And then you say that we can't fix this health equity. So it is a multi-pronged solution, right? So a lot of it is, yes, physician office, but where's the community engagement? How can we partner with community-based organizations?
Meet them where they are.
Meet them where they are, whether it's homeless shelters, perinatal collaboratives, whether it's the Salvation Army, a Boys and Girls Club. How do we form that wraparound support? Pulpit power churches. We in Meridian, we contract, or we are partnered, not contract. We're partnered with our churches to spread the messages, and we host fairs inside their parking lot, and they tell their congregation show up, and that's, for me, cultural literacy, we're meeting.
Yeah,
So
absolutely.
community engagement.
I was going to say, so as a pediatrician, I'm curious if you said, like, how you said, like, if we fix things now, especially for young people, we have a huge ROI 20 years down the line. It's hard to convince, I'm just going to say, payers to that's maybe worth the investment now, because they're not going to see that turnaround immediately in the next 1, 2, 5, 10 years, but it will pay off later on. Am I off base here, do you think, or are a lot of efforts being put towards children, and enough so to make that impact later on?
I think that what's surprising when we get to the managed care side is everybody's on the same side. And in the sense that our government, right, the federal government, CMS, will also, we have guidelines that we have to get towards, where this is the inequity. We are now responsible for calculating disparities.
How the calculation for pediatrics, though, is going to be like a very little sum of the big pot. However, I think in time, it's still the ROI could be much, much larger than in some of other initiatives based on like small parts of adult health. I think it's my opinion. I think that's why maybe I struggle to see a lot of the implementation of pediatric initiatives. Again, I could be very wrong. This is your space. I would love to hear your opinion on this.
No, I think it's a good. It's a very good point. So pediatrics and health equity. I think it's important from a payer perspective. Lyndsey, you would be surprised to know that for us, when I'm looking at HEDIS measures, almost, especially for the Medicaid population, moms and babies, It is primarily HEDIS, for
Yes.
peds, and then the perinatal measures, for
Yes.
mom, right?
I've seen that a lot lately. I think that's a very hot topic right now. The moms and the infant stage up to 1 year of life. Absolutely.
So, right. So, and that's how we are adjudicated. There are pressures. I think that, it's always follow the money trail. And what we're noticing in more and more states is as health plans are coming up for rebidding for a way we want the right to have, we would like to care for our members in this line of business, especially if it's Medicaid, where the states are coming back and saying, but what are you going to be doing to close these disparity gaps?
Yeah.
Measure the gaps, close the gaps, and your reimbursement will be based on the gaps. So there's a lot of momentum in the background that you may or may not be seeing. For us, it translates into investment. Like I talked to you about our community health workers, who are our foot soldiers. It is community engagement where we've had hundreds of events in the community, where we patients who may not go to their physician are told to go to the physician if they stop by at a booth, right?
Right.
And also partnership with our FQHCs, where what support do you need? What can we give you, to reach that gap? I think that social needs, behavioral health / social needs, forms a part of it. And when we say it's an uphill battle, are we seeing more and more investment and access
Yes. Right.
to those services? I think, would also help offload physicians from taking care of, behavioral / social needs in a visit where they have to take care of the clinical needs. And I think the more that physicians can start seeing that, the easier it would be for you to do your job. And hopefully
Absolutely.
that's where we're increasingly going.
Which I think brings us to a next great topic of talking about innovation and technology and how we're utilizing these things to make the change and maybe take the onus off of, let's say, like a clinician to do the social aspect or the background social determinant of health that you're discussing. Are there great innovations that you can share, or things that have been really interesting that have really changed the way that we practice now, or maybe will, or that have improved that bottom line and or retained an ROI?
I think there's an innovation all of us know that really profoundly changed medicine since COVID, and it's telemedicine. Right? Because like before that, we didn't do telemedicine. We didn't know telemedicine. And it was like, come on, we didn't even know how to bill for it. We weren't set up for it. Patients didn't know how to log on to it. And once we did it, it's almost like we opened a door that's not going back, and it's a great equalizer. So telemedicine is a health equity equalizer. Virtual visits may or may not be because of the access, like a rural health disparity, access of broadband, access to a smartphone or, visibility, but it can also be an equalizer because certainly you're preempting that step of having to get to your doctor who may or may not be close to you, or even there. So I'd say the biggest disruption, and it's not a fancy one, but it's us thinking, being forced by COVID to think out of the box of a physician visit is also pick up the phone. And I think that these are ways we change with time. Where I can see innovation happening is member patient directed care, right? Whether it's virtual apps, right? Where
that's my Blueberry Pediatrics. It's the whole premise of our business. So you're certainly talking to someone on the same side there. I think being able to give them access. The big key, access to great care in the home, to know what's the next step. Do you have to go to the emergency room? Do you need to see the subspecialist? Which is the next best step to getting you the quality care that you need and not wasting your time, energy, money. Win, 100%.
Right. And then virtual care absolutely can kind of close that gap of, can we have consultative care in a, virtual consultation in in an area where you don't have a pediatric gastroenterologist, right? But we can do that. So it's another way to close that gap. And I agree. I think a lot of times when we think of virtual solutions like apps, there's a role for them. And I think that as clinicians opening up our minds to the fact that, we're used to medicine in a certain way, this is not going to replace it, because we need it all. We need this and this and this, because we're not achieving health equity.
Yeah.
And
Do
it's going
you
to take,
find that people fight that? Because
yes,
it's change. Change is hard.
yeah.
And yeah, do you find that that's difficult to implement on like a big scale?
It's really interesting. So I try to in California, we try to implement a patient care app. And what's really interesting is there's two apps we tried to implement. There was less of an uptake in the general, the older population, very much an uptake in the pregnant woman. Um, because there's an engagement, right? There's an
Yeah,
engagement. It's probably the age, the knowledge of the app, right? So it's what cohort are we going for?
that makes sense.
So I really think it's finding that, that sweet spot of, member engagement, member need, filling a need that people may or may not have known, and then, getting that voice out that this is available and finding how to meld that into care delivery. I think if we don't find those solutions, then we run the risk of becoming obsolete, right? And
Absolutely. Yeah, that's a
we
great
want to
point.
stay in the game. We want to stay in the game as physicians. So I want to say, did you look at your app? What did the app say? It said this. Well, this is good, but this is not right. Not for you, right?
Hmm.
And I think that those are ways we need to now consider virtual care complementary to our practice, be open to it, and to leverage it, for health equity and for all of our members.
Yes. So, what advice as a healthcare leader would you give others in order to drive innovation and make create change within their organizations?
So I'll say, like for DEI and health equity, I would say, um, be the change, advocate. I'd say advocacy is intersectional,
Hmm.
right? Let at any given time as clinicians, physicians, can we say, who is the most vulnerable voice in the room? Whose voice is not being heard right now, right? And how can I elevate that voice? And there's a lot of voices that are not being heard right now in national conversations. And I think it's up to physicians to say, there's a reason that this impacts health and healthcare delivery, right? So I think feel empowered that each of us is a community, social, political advocate for the health of our nation. So never feel. I mean, the fact that we went to school for so many years, we deserve that place of now sharing that information for the health. So one is be empowered for healthcare delivery, and health equity is speaking to the most vulnerable. And the other is like start small. The third is if you want to start anything in your organization, find the ROI, right? Everyone knows things are good to do, but let's find a way to make it. Hey, did you know that we have this much of a quality bonus from CMS if we fulfill these measures? We missed $500,000 of it. If we had invested in one social worker, we would
Hmm.
have been able to get that. Give me that social worker, I will give you that quality, incentive bonus that might be coming from the, whether it's a managed care plan, or from CMS, right? So I'd say educate yourself. Financial literacy is also important for change. And look at your organization's financial imperatives, and use your clinical judgment to say, how do we align those financial imperatives with health equity and healthcare delivery? And the more physicians we have in that room, the better the solutions are going to be.
Great advice. We have a few minutes left. I'd love to hear from you. Anything else you'd like to share for either people who are passionate in this space, clinicians who are practicing, people who want a future in this space, want to advocate for those who don't have voices. Anything I may have left out in questioning in the short time we have together.
Um, no, I'd say feel empowered. I say disconnect from the politics of health equity, because in the end, equity is all of our patients deserve equal outcomes, and I don't think there's a clinician who thinks otherwise, right?
Right.
So I think that for us, it's a very clean advocacy of health. And I would say that, when we're looking at the national conversation, I think the conversation in healthcare is clean. It's what do we need to do to get to equal health for all? So if we're not stepping in the conversation because we're worried about saying the wrong thing, I would empower us to step up, to start having scientific voices in the room, clinical voices in the room. So I would love it, connect in social media. I also think the last 10 years, especially 5 years, there's a huge coalition following in social media, whether it's Facebook, LinkedIn, TikTok, of elevating voices, connect with people, and then elevate others, right? So if you're working, you elevate voices that deserve elevation. The last thing is I also think, much as I want to create change, a lot of times I find my best effort is to center the person who's making the change and center their voice. So there may be people in your organization that are doing great work that have not had the support, or
You
leadership.
add the perspective, a different perspective.
Right. And then you say, hey, do you know Dr. So-and-so is out there doing street medicine and he's been asking for funding, but if we invest, this would really help this, and this, right? So I think part of being the change is we don't have to do it all ourselves, but we can be part of a community that's recognizing, advocating, and supporting advocacy. And I think in that I'm very optimistic. I think we've already seen a change in awareness. And Dr. Garbi, like you, I'm very interested now in outcomes because I'm holding us accountable to outcomes now. And it needs to happen in our lifetimes. And I'm optimistic it will.
I hope so. I will be optimistic with you and work towards it as well. Thank you all for tuning in to today's episode. Be sure to subscribe to the show for more episodes. And if you love the show, if you haven't already, please be sure to leave us a 5-star review.